The most important part of helping me prepare for a PABST case is gathering all the preoperative information that's necessary to plan appropriately. And so for patients with a tibia non-union, for example, it's important to have full-length standing films from the iliac crest to the foot, showing bilateral limb length comparison. And I also like to get 36-inch cassette full-length orthogonal films of both tibia, as well as CT scan information if necessary. And really this is critical to gather information on the size of the defect and to plan accordingly for the case. So it's important to gather this information preoperatively in order to plan for the case. We're looking at things such as length as well as diameter of the intramedullary canal in order to have the appropriate implants for the case. It's important to plan for both the plate and the plate-assisted bone transport as well as the NuVasive precise implant. Communication is critical. The success of the surgeon and patient in a PABST case is critically dependent on the preoperative plan and the amount of work performed by the surgeon and information gathered. It is of utmost importance to plan, so that once the patient is in the room, the execution of that plan has been gone through many times, and it's simply carrying out the plan. This is much different than a tibia or femur fracture acutely. A significant amount of planning is required in order to have the appropriate equipment and set the appropriate expectations for the patient. As I'm planning for a PABST case in this tibia, for example, it's important to have full-length films of the tibia that are calibrated in order to get an accurate length of the tibia. This can also be gleaned from CT scan data, and oftentimes for these cases, most often we have a CT scan. We're looking at length as well as the diameter of the intramedullary canal, and this is important for both the plate application as well as the intramedullary nail application. The other thing that's important to consider is the size of the defect. And I like to plan these cases with the defect that I believe will be the case, as well as a contingency plan should the defect be larger. This is important based on the length of the nails. There is a varying degree of excursion that the nail will telescope. So it may be important for your case to have multiple different lengths and diameters available. Briefly, the technique for the plate-assisted bone transport involves a plate as well as the precise intramedullary nail. Here's a model of the tibia and fibula. The sequence of steps would be, as you can see here, we've, in this model, assessed the bone defect and performed the appropriate debridement or resection, creating our space and preparing the docking segment. Here you can see the plate. This is a medial-based plate on the distal tibia. This plate is serving as railroad tracks, effectively. We are connecting the distal segment to the proximal segment. The intramedullary nail, as you can see here, is placed, as with any standard tibia intramedullary nail for fracture, but in this case, it is stopped short in the segment that we are wishing to transport. Here you can see the distal crosslock screw, and prior even to placement of the intramedullary nail, the surgeon will have created a low-energy osteotomy. And here you can see that osteotomy. The surgeon would have performed this based on the plan and a series of measurements. That osteotomy is performed under low energy, low heat, and this will be the segment that over the next weeks to months will be transported, in this case from proximal to distal. In the acute setting, infection management consists of treating the patient appropriately based on their soft tissues. In most cases, that's using PABST as a staged treatment. These are patients with open wounds, bone defects, poor physiology, given their traumatic injuries. In that setting, in a patient in that physiologic state to jump straight into PABST as the primary treatment, I think that would increase the risk. So typically we're treating the patients in stage fashion, using a cement spacer, allowing the soft tissues to heal, allowing the swelling and soft tissue envelope to come back to baseline, thereby lowering the risk when we perform the PABST treatment down the road. In the non-union setting, as with any non-union, it's important to obtain all of the infectious lab work, advanced imaging studies, and if we do determine that the patient is infected or likely to be infected, or there is intraoperative information consistent with infection, then that would be a patient to treat staged with a debridement and resection in some form of bone stabilization, and that would go from one surgery to a staged surgery with PABST as the second surgery with removal of hardware once we're confident that the infection is cleared. When performing the PABST with antegrade push technique, it's important for the surgeon to achieve alignment of the tibia. In this case, we've used a plate. The plate is spanning the segment from distal to proximal, and it's critical to restore all parameters of alignment. Once this is done, we're using the intramedullary nail to guide the transport segment distally. The plate medially and the intact fibula laterally are essentially acting as train tracks in order to maintain position of the transport segment. When performing the PABST technique with an antegrade push technique, the plate medially and the fibula laterally keep the transport segment well aligned, typically in the coronal plane. What I've found in the sagittal plane is with transport, the segment can be off course either anteriorly or posteriorly. So as it approaches the docking site, there are techniques that I've utilized in order to maintain alignment of the transport segment with the distal segment. My postoperative latency protocol differs for tibia and femur. For tibia, the latency period is typically 10 to 14 days. I feel that there's decreased vascularity with the tibia and reason to delay to that time point. I will change that latency period closer to 14 days if the patient has other physiologic risk factors such as tobacco use or diabetes. And for a healthy person with no other medical problems, a tibia latency period would be approximately 10 days. For a femur with a better muscular envelope, the latency period is typically 7 to 10 days. Once the latency period has completed, my rate and rhythm is approximately 1 millimeter per day. I find that patients tolerate that better doing it in three intervals rather than 4 times a day. And so I've noticed that patients are much more adherent to a schedule with 3 sessions per day rather than 4. I do 1 millimeter a day for both, but that same patient group that I'm more likely to have a longer latency period, I'm also more likely to decrease that from 1 millimeter to 0.75 millimeters a day. And that, my rate and rhythm may change throughout the postoperative period as well, based on interaction with the patient and radiographic results that we're seeing. So postoperatively, the first visit occurs at approximately 2 weeks, which is standard. So radiographically, we're able to look at various parameters on the radiographs to determine that the nail has moved appropriately. And so we can look at the area in the magnet as well as the distal nail. We can take those measurements on calibrated x-rays and confirm that it has moved the appropriate amount based on the number of cycles performed. As the patients are progressing through their PABST postoperative protocol, it becomes even more critical to see them back frequently in the office. And so as we're nearing the end of the transport across the bone defect, we see the patients as often as necessary, sometimes every 3 to 4 days. They can be seen 2 times within a week. And so once we're at that point, based on calibrated x-rays, we're determining to the day when their docking will occur. There are times where I have not taken the patient back to the operating room for a specific docking procedure. If I see that the tibia antegrade push segment is transporting perfectly in all planes, it's a young, healthy patient with no medical problems, I may not return to the operating room. On the other hand, there have been patients where there is sagittal plane deformity with as the transport segment heads distally. I've taken those patients back to the operating room when it's 1 millimeter away from docking. In those cases, I'll make an incision, perform a debridement at the docking site. In PABST, for patients with the antegrade push technique for a tibia, as there is sagittal plane deformity and we've planned for an intraoperative docking site procedure, we can make a small incision for clearing fibrous tissue at the docking site, bone graft as you see fit, but we're also able to control the sagittal plane malalignment through percutaneous techniques or a very small incision, guide this transport segment back in the appropriate position, and through another percutaneous incision can place a non-locking cortical screw into the segment to help maintain the position. That single screw will not prevent additional compression from occurring, but will help maintain the position of the transport segment with the distal segment. For patients that have undergone the docking procedure in the operating room, and I'm going to have them continue the external device 3 times a day, I'm seeing them back on a regular basis. So for somebody that's had a surgery performed early in the week for docking, I'll see them back later in the week. If it's a patient that it was later in the week, I'll see them back on Monday. They're continuing the same routine they've continued, and then when I see them in the office, what I'm looking for is maintained compression at the docking site, and another objective measurement that compression is continued is we can often see the distal crosslock screw slightly bend. Once I've seen that, those patients stop the external compression device at that time.